Okay, sorry for that interruption. We are going to continue now. Now, I stated earlier that the fluid requirement in the tropics is higher than that of the temperate region because tropics is usually hotter, and being hotter, the amount of fluid that is lost is higher. Okay, so the total fluid requirement in the tropics now is higher. And generally, fluid intake is equal to output, okay? And if the input is more than the output, patient will tend to retain fluid, okay? And if the output is more than input, that means patient is losing fluid, okay? Now, in the tropics, the total fluid requirement of a surgical patient, don't forget, in the tropics, the total fluid requirement in a surgical patient, adult surgical patient, is 3 liters. And this 3 liters is derived from the total amount of fluid that is lost. The total 24-hour urine that is lost in the tropics is 1,500 mils. In the tropics, an adult loses up to 1,500 mils. And the amount he lost via insensible loss, amount lost via insensible loss is 1,700 mils. Now, when you say insensible loss is the amount that is lost via the breathing, as well as the amount that is lost via skin, that is insensible loss. And in the tropics, it is 1,700 mils, okay? Yes, so you have, let's go back to this option. Total daily fluid requirements in a surgical patient is 3,500 mils. Yes, so this is false because we say the total fluid requirement in the tropics is 3,000 mils. Total daily insensible loss is 1,700 mils. This is correct. Total daily urine output is 2,000 mils. Okay? Now, you should know that the total urine output in an adult in the tropics, I said, is 1,500 mils. So this is false. Endogenous water production is 500 mils, which is false. Endogenous water production is 200 mils. So that is water that is produced from metabolism, okay? It's 200 mils, okay? So this is also false. Now, 50 grams of glucose provided in fluid eliminate gluconeogenesis. Now, you should know that 50 grams is too small to achieve, to prevent gluconeogenesis. The minimum amount of glucose that is required to prevent gluconeogenesis or to reduce gluconeogenesis to the barest minimum is 100 grams, okay? Is 100 grams. Yes. So let's move to the next question. The next question is concerning dehydration. okay, concerning dehydration. Acute dehydration is mainly ICF loss. Acute dehydration is mainly ECF loss. Okay? Acute dehydration is mainly ECF and ICF loss. Chronic dehydration is mainly ICF loss. Chronic dehydration is mainly ECF loss. Now, about dehydration, you should know that when patients suddenly lose fluid acutely, that fluid loss is mainly from the extracellular compartment. But when this fluid loss is chronic, the fluid loss is both from the extracellular and intracellular compartment. Okay? I'll take that again. When a patient suddenly loses fluid, that fluid, that is acute loss, is mainly from the extracellular compartment. For example, when a patient vomits, okay, when a patient is passing acute diarrhea, that is mainly loss from the ECF compartment. But when that patient is having chronic dehydration, like from gastric outlet obstruction, the loss is from both the ECF and the ICF. Okay, the loss is from both the ECF and the ICF. Okay, now this is very important in a surgical patient, ECF, acute and chronic dehydration. And the reason why it's very important, because when a patient suffers acute dehydration, the resuscitation is immediate. Okay, you require a rapid replenishment of the fluid that is lost. While if a patient is having a chronic dehydration, you do not replenish that rapidly. Okay, because if you attempt replenishing that rapidly, patients will develop central pontine demyelinosis. Patient may also develop fluid overload. So it is very important you know that fluid replacement is done slowly in chronic dehydration. Okay. So let's go back to this option now. Let's look at the options. We said acute dehydration is mainly ICF loss. That is false, because we said acute dehydration is mainly an extracellular fluid loss. So A is false. Okay. B says acute dehydration is mainly ECF loss. So B is correct. Okay. Then acute dehydration is mainly ECF and ICF loss. That is false. That is for chronic dehydration. Then chronic dehydration is mainly ICF loss. Chronic dehydration is both ICF and ECF loss. So that is false. Chronic dehydration is mainly ECF loss. That is false. You can see, if you don't know this and you see questions that are similar, it may cause confusion. Okay, it may cause confusion. So you need to be very conversant and pay close attention to to the options so that you don't run into trouble. Okay. Okay. So let's continue. The next question is regarding gastric outlet obstruction. Regarding gastric outlet obstruction. Now, both ECF and ICF are lost. B, there is hyperchloremia. C, there is mild hypokalemia. D, there is metabolic acidosis. E, the fluid of choice for correction is Ringer's lactate. Okay, now remember, in a patient with GOO, gastric outlet obstruction, patients have chronic dehydration. That is, patient is having both ECF and ICF loss. Secondly, don't forget, in a patient with GOO, he has hypochloremic, hyponatremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. Those are the fluid and electrolyte changes with chronic dehydration. So let's go to this option. The first option says both ECF and ICF are lost. That is correct because it's a form of chronic dehydration. Okay, so A is correct. B says there is hyperchloremia. B is false. Why is B false? Because they have hypochloremia. They vomit predominantly hydrochloric acid. And when they vomit hydrochloric acid, they will have hypochloremia. Okay? Yes. Now, because they are vomiting acid, they will have metabolic alkalosis. So C said there is mild hypokalemia. Now, the hypokalemia in a patient with GOO is marked hypokalemia because they are losing potassium in the vomitors as well as potassium in the urine. Okay, so the potassium loss in gastric outlet obstruction is critical. So it is not a mild hypokalemia. That is false. There is metabolic acidosis. That is false because they are losing acid. They develop metabolic alkalosis. Okay, they develop metabolic alkalosis. Okay, so the fluid of choice for correction is Ringer's lactate. Now, don't ever forget, Ringer's lactate is contraindicated in a patient with gastric outlet obstruction. Ringer's lactate is contraindicated in a patient with gastric outlet obstruction. Why is that so? Because they already have alkalosis. Ringer's lactate has lactate that is converted to bicarbonate in the liver, and that bicarbonate will further worsen the alkalosis. Okay, that will further worsen the alkalosis. Okay. The next question now is concerning fluid overload. Concerning fluid overload. It's particularly related to parenteral administration of saline-containing fluid. B, it causes reduced ICP. Okay. C, renal failure, hypoproteinemia are not a risk factor. D, spironolactone is a drug of choice for treatment. Then E, central venous pressure is less than 15 centimeters of water. Okay, now, fluid overload, when the total fluid input is more than the output, that means patient is retaining fluid. And when patients that are prone to fluid overload are patients with major organ failure like congestive cardiac failure, renal failure, hypoproteinemia, okay? They are patients that are at risk. Patients that have poor handling of excessive fluid, okay? So let's look at the options now. It's particularly related to parenteral administration of saline-containing fluid. That is correct because it tends to expand the extravascular space, okay, intravascular space. And when you oversaturate the intravascular space, this fluid moves into the interstitial space, okay? This fluid moves into the interstitial space. It causes reduced intracranial pressure. That is false. When there is fluid overload, patients develop raised intracranial pressure. And when they have a raised intracranial pressure, they will have headache, they will have vomiting, they will even convulse. So fluid overload is a cause of raised intracranial. So that is false. C, renal failure, hypoproteinemia are not a risk factor. Okay, this is false because we said renal failure, congestive cardiac failure, hypoproteinemia, all these are risk factors for developing fluid overload, okay? Spironolactone is a drug of choice. Okay, so this is false. This is a potassium-sparing diuretics, oral. So you use furosemide as your drug of choice. Okay, so central venous pressure is less than 15. So if it's less than 15, that is normal because normal central venous pressure is 12 to 15 centimeters of water. So when they have fluid overload, their central venous pressure will be elevated, okay? So the next question is on hypokalemia, okay? Hypokalemia is a serum potassium less than 3.5 millimoles per liter, okay? Is a serum potassium less than 3.5 millimoles per liter. Okay, B says it's usually due to gastrointestinal losses. C, present with muscle weakness and slurred speech. D, ECG shows depressed ST segment, inverted T wave, and U waves. E, potassium chloride is given rapidly for correction. Now, note that all these options from A to D are correct. Potassium chloride is one of the drugs you do not give in bolus. You don't give rapidly. If you give rapidly, patient may develop um, cardiac arrest. So serum potassium, normal serum potassium is between 3.5 to 5.6 millimoles per liter. So when you have a serum potassium less than 3.5, that is hypokalemia, okay? And it is usually due to gastrointestinal losses from vomiting and diarrhea. That is correct. Present with muscle weakness and slurred speech, okay? Because potassium is very important for skeletal and smooth muscle contractility, as well as cardiac contractility and generation of action potential in nerves. So when you have low serum potassium, all these functions are impaired. ECG shows a depressed ST segment. So remember this, the ECG features of hypokalemia are depressed ST segments, okay? The firing is reduced, ST segment is reduced, inverted T wave and prominent U waves. KCL is given rapidly. We mentioned that KCL is never given in bolus, okay? The next question is hyperkalemia. Hyperkalemia. Now, a serum potassium is over 5.5 millimoles per liter. Okay. B, seen in severe metabolic acidosis. Okay. C, ECG changes are very short T waves. Okay. D, calcium gluconate is the initial most important treatment. E, glucose insulin infusion is used in the treatment. Okay. Now look at all these options. Serum potassium is over 5.5. That is correct in some labs, 5.5, 5.6. So when it is greater than 5.5, it's also hyperkalemia. Okay. So seen in severe metabolic acidosis. So you should remember hyperkalemia is seen in metabolic acidosis. Hypokalemia is seen in metabolic acidosis. Okay. So ECG changes in hyperkalemia is a tall tented T waves, and this is a very short T wave. So this is false. Don't forget. Okay. Always remember, when you talk of hyperkalemia, the ECG change, remember a tall tented T wave. Calcium gluconate is the initial most important treatment. Yes, because if a patient have hyperkalemia, one of the most feared complication is cardiac arrest. So the first initial treatment is to protect the heart. And to protect the heart, you give calcium gluconate. Then glucose insulin infusion is used in treatment. And the essence of that is to push the potassium into the cells. The insulin will push the potassium into the cells. Okay? Yes. So let's talk about hypomagnesemia. Hypomagnesemia. Hypomagnesemia, A, considered in any patient that has been on a drip for more than 7 days and shows behavioral disturbance. Okay. B, presents with hyperreflexia. C, Trousseau's and Chvostek's signs is not a feature. D, can be corrected with 1 millimoles per kg in 5% dextrose water over 4 to 8 hours. E, pancreatitis is a cause. Okay. Okay. Now, look at all these features. You know that magnesium is an important micronutrient that features of its deficiency may manifest like patient with hypocalcemia. Okay, and it's usually common in patient that has been on nil per oral for a very long time. Okay, especially patients on TTN or patients on IV fluid. Okay, and they show some features of features that are similar to those of hypocalcemia, like hyperreflexia. So if you look at this option, A says it's considered in any patient that has been on drip for more than 7 days and shows behavioral disturbance. That is correct. Okay. Present with hyperreflexia. That is correct. Trousseau's and Chvostek's sign is not a feature. That is false because these are features seen in hypocalcemia as well as hypomagnesemia. Okay. Yes. Now, C is false. Can be corrected with 1 millimoles per kg in 5% dextrose water over 4 to 8 hours. That is correct. Pancreatitis is a cause. So your answer here is C, that is the negative option. Now, hypocalcemia. Hypocalcemia, hypoparathyroidism is a cause. Okay? Yes, when you have hypoparathyroidism, you see mobilization of calcium will be impaired, so they will have hypocalcemia. Okay. B, hyperparathyroidism is a cause. That is false. Corrected with calcium gluconate given in bolus. Remember, calcium gluconate, calcium chloride are never given in bolus. Twitching of the facial muscles when tapped at the facial nerve is Trousseau's sign. Okay, that is false because when you twitch, when you tap the facial nerve at its exit, okay, and you have twitching of the face, that is Chvostek's sign. Trousseau's sign is when you have spasm. There is spasm of the hand, okay? You have carpal spasm. When you inflate a BP cup up to 20 millimeters of mercury above systolic pressure of that individual, you now see patients having twitching of that hand. That is a Trousseau's sign. So here, this is false. Bone metastasis is a cause. So bone metastasis, you rather see hypercalcemia, not hypocalcemia. Okay. Now, regarding normal saline, which is false. Now, normal saline is an important fluid. Okay. Regarding normal saline, which is false, contain 154 millimoles of sodium per liter of water, okay? contains 154 millimoles of chloride per liter of water, 0.9% saline, hypotonic, hypertonic. Now, A is correct, okay? It has 154 millimoles of sodium in a liter of water, okay? B contains 154 millimoles of chloride in a liter of water. That is also correct. It is also called 0.9% saline. That is correct. That is 9 grams of sodium chloride in a liter of water. So it is hypotonic. That is false. It is slightly hypertonic. So D is the only negative option here. So D is false. D is the only correct option there you pick. Now, regarding Ringer's lactate, the most physiologic intravenous fluid, Now, you should know that Ringer's lactate is the most physiologic fluid because its constituents are similar to those of plasma. The constituents are similar to those of plasma. Now, it contains 4 millimoles of calcium per liter, okay? That is also correct. It contains 4 millimoles of potassium per liter. That is also correct. Does not contain bicarbonate. It contains bicarbonate, about 27 millimoles of bicarbonate. So that is false. Contains 130 millimoles of sodium per liter. Okay, that is correct. So the only false option here is D. Okay, so it contains 27 millimoles of bicarbonate. Intravenous fluid, which is false. Are crystalloids or colloid? That is correct. Intravenous fluids are either crystalloids or colloids. Full-strength Darus contain 36 millimoles of potassium. That is correct. So you should know there are two types of Darus solution: the full-strength Darus and the half-strength Darus solution. The full-strength Darus contain 36 millimoles of potassium, and the half-strength Darus contains 18 millimoles of potassium. Okay? Pediatric saline is hypotonic. Now, you should know that pediatric saline is a hypertonic solution. So this option is false. Okay? Its osmolality is higher than that of the plasma. Human albumin is the most physiologic colloid. That is correct. Human albumin is the most physiologic colloid. Imacil is contraindicated in established renal failure. Imacil is contraindicated in established renal failure. Okay. So this is also true. Okay, it's also true. Imacil is contraindicated in patients with renal failure. So our answer here, pediatric saline, is the correct option. Okay. So let's proceed. Regarding shock, which is false. A, cellular hypoxia is the hallmark. Now you should remember, shock is a clinical manifestation of failure of cellular function due to inadequate tissue perfusion with consequent cellular hypoxia. So hypoxia is the hallmark of shock, resulting from effective circulating blood volume. So hypoxia is the hallmark of shock. Now, acute hemorrhage is the commonest cause of shock. Acute hemorrhage is the commonest cause of shock. That is correct. Bleeding. Hypovolemic shock. And you should remember, hypovolemic shock, there are two types of hypovolemic shock. There's the hemorrhagic and the non-hemorrhagic. Okay, when you say hemorrhagic, it's when you are losing blood. While non-hemorrhagic, one is losing extracellular fluid from vomiting, diarrhea, loss from intracutaneous fistula, and so on. Now, acute hemorrhagic is the commonest cause of hypovolemic shock. 25% of total blood volume is lost for shock to appear. You should remember 25% of total blood volume must be lost for shock to appear. This is also correct because there are different classes of hemorrhage. There is class 1 hemorrhage, class 2 hemorrhage, class 3 hemorrhage, and class 4 hemorrhage. It is when patients develop, from between class 3 hemorrhage to class 4 hemorrhage, that is when you see patients are developing shock. But you should know a minimum of 25% of total blood volume is lost for patients to develop shock. That option is correct. Cardiogenic shock is a form of distributive shock. Now, cardiogenic shock is not a form of distributive shock. When you say distributive shock, it's a shock that results as a result of peripheral vasodilation of vessels. Peripheral vasodilation of vessels. Peripheral vasodilation and pooling of blood. And it is the capacitance vessels that dilate and pull blood to the periphery. Patient develop a form of distributive shock. Okay. Now, what are the distributive shock? Patient with anaphylactic shock, neurogenic shock, and septic shock. These are distributive shock. They result in a peripheral vasodilatation of capacitant vessels. So cardiogenic shock is not a form of distributive shock. Each heartbeat propels about 70 to 90 mils of blood at a pressure of 120 millimeters of mercury. That is correct. Regarding shock, which is false, potassium leaks out of the cell. Okay, that is correct. That's why you see when they lose a lot of fluid, they develop acidosis and hyperkalemia. So in shock, patients have hyperkalemia. Sodium and water enters the cell. Sodium and water enter the cell because you see when a patient develops shocks, okay, what happens is they lose a lot of blood, they develop hypoxia, and hypoxia will lead to anaerobic respiration and insufficient ATP. will be produced that maintain the sodium potassium pump. And when there's disruption of the sodium potassium pump, there is movement of fluid into the cell as well as sodium, and the cell will swell and burst. So it happens. B is correct. Concentration of cyclic AMP falls. Yes, that is correct. Only 38 ATPs are produced in the cell. So regarding shock, which is false, in shock, you have only 3 ATPs that will be produced rather than 38. Okay, mitochondrial function is reversed. That is true. Now, the early phase of shock, which is false. Now, there are 3 phases of shock. There are 3 phases of shock. The early phase, the middle phase, and the late phase of shock. In the early phase of shock, okay, is a compensatory mechanism that is carried out by the baroreceptor mechanisms. The middle stage of shock is maintained by the renin-angiotensin-aldosterone mechanism. And the late phase of shock is a stage of decompensation where all the compensatory mechanisms of the body are lost. Okay, so those are the 3 phases. Okay, this option says in the early phase of shock, there is diminished afferent impulse from the baroreceptors to the cardioinhibitory center and vasomotor center. So this is correct because when the patient loses blood, what happens? The tension within these blood vessels is reduced. And when the tension reduces, there's stimulation of the baroreceptors that sends signal. It sends an inhibitory stimulus to the cardioinhibitory center and a stimulatory impulse to the vasomotor center so that the heart rate will increase and patient will also have vasoconstriction, aiming in elevating the blood pressure as well as increasing the peripheral resistance. So A is correct. B, there is decreased vagal activity. Of course, there is decreased vagal activity in a patient with in shock, in the early phase of shock. There is vasodilatation. This is false because the baroreceptor, the vasomotor center will cause sympathetic release, adrenaline, which will cause vasoconstriction. Okay. Now, they said, D said there is increased rate of sinoatrial node, yes, because of stimulation of the cardioinhibitory center, inhibition of the cardioinhibitory center, the stimulation of the electrical activity to increase heart rate. There is constriction of the arterioles, that is correct. In the middle stage of shock, there's a release of renin. Yes, we said it is mediated by the renin-angiotensin-aldosterone pathway. So A is correct. Angiotensin 2 is formed, that is correct. The aim of angiotensin 2, they have direct vasoconstrictive effect, okay? Angiotensin 2 also stimulate release of aldosterone to cause reabsorption of salt and water. It stimulates test centers. It also stimulates release of ADH. cerebral blood flow is decreased. Now, you see in middle stage of shock, there is diversion of blood from the periphery, okay, and dysplasmic circulation to supply the brain, okay? So this is false because cerebral blood flow will increase. There is diversion from the periphery to supply the CNS. So this is false. Splanchnic vasoconstriction occurs. That is true. In the late stage of shock, there is decompensation. It is called a phase of decompensation. The compensatory mechanism of both the baroreceptors and the renin-angiotensin aldosterone pathway are all lost. So you have a phase of decompensation. Cerebral blood flow decreases. Okay, cerebral blood flow decreases. Now, you should know in the stage of decompensation, even the mechanism that protects the vital organs, the brain and the heart, is lost. So they have decreased blood flow to the CNS. Okay, after that, you see the CNS will malfunction, the heart will also malfunction. There is increased coronary perfusion. You see, here it decreases because the body is not even having enough blood to supply the heart and the brain, so it decreases. Baroreceptor fail, it has already failed, it's a decompensated state. Patient developed MODS. Yes, the brain has failed, the heart has failed, all organs have already failed. Regarding shock, which is false, the most reliable marker for tissue perfusion is urine output. That is correct. Okay, so when you are resuscitating patient in shock, you have to be monitoring urine output. Pulse is rapid, weak, and tready. That is correct. Blood pressure may be unrecordable. That is correct. Skin is dry. Okay. Now, patient in shock, the skin is wet. Okay. It is cold because of decreased perfusion, and it is wet because of stimulation, sympathetic stimulation of the sweat glands. You know, during shock, there is sympathetic outflow, and this stimulates the sweat gland to be producing sweat, so it will be wet. So D is false. Breathing is rapid and deep. This is called air hunger. Treatment of shock, which is false. Use of tourniquet is the first step. That is false because you have to secure intravenous access and commence IV fluid. Okay. You elevate the foot of the bed. Yes, this increased cardiac output by 20%. Commence fluid replacement with crystalloid rather than colloid. Yes, it's you use crystalloid in the initial resuscitation of fluid. Okay, even though 1/3 of the crystalloids remain in the intravascular space, 2/3 diffuse into the interstitial space. Okay, so it carries more oxygen and nutrient now. Dislodge microthrombi. Why, if you give colloid, it remains only in the intravascular space? Oxygen is excess. In excess is avoided. Okay, yes. Fresh blood is preferred. So your correct answer here is A. You don't use tourniquet. Regarding hemorrhage, class 1 involve loss of blood of loss of 25% of blood volume. Now, there are 4 types of hemorrhage, class 1 to 4. Class 1 is loss of up to 15% of blood volume. Class 2 is loss of 15 to 30% of blood volume. Class 3 is loss of 30 to 40% of blood volume. And class 4 is loss of more than 50% of blood volume. Okay. So now if you look at all these options, the only correct option here is C. Class 3 involves loss of 30 to 40% of blood volume. Okay. Now we'll just briefly look at some imaging. Now, the differential diagnosis of dysphagia, difficulty in swallowing, include achalasia, esophageal tumor, and esophageal stricture. This is a barium swallow. It's an image of a barium swallow. Okay. This is an image of a barium swallow. Now, before we go into achalasia, okay, you should know that the difference in the history of a patient with achalasia and a patient with esophageal tumor, okay, the patient with esophageal tumor, they usually have a progressive dysphagia over short time, okay? A progressive dysphagia, and the duration is shorter than a patient with achalasia that will be having intermittent over a longer duration of time. So this image, if you see something like this on your picture test, it is barium swallow. You can see a contrast is outlining the esophagus. When a contrast outlines the esophagus, that is barium swallow. If it outlines the stomach, that is barium meal. If it outlines the small intestine, that is barium meal and follow through. Okay. Now, and remember, barium enema is outlining the colon, and the instillation is from the rectum. Now, let's briefly look at achalasia. Now, achalasia is due to reduced number of ganglion cells in the myenteric plexus, okay? Vagi show axonal degeneration of the dorsal motor nucleus and nucleus ambiguous. The etiology is unknown, but a neurotrophic virus may be important. It's similar to the Chagas disease due to Trypanosomia cruzi. Now they lost their ganglion cells of the esophagus, okay, the vagi, and there's loss of that lower esophageal sphincteric tone. So you have, they will present with a dilated esophagus, and they will have difficulty in swallowing, okay? So commonest in patients between 40 to 70 years, male-female ratio is approximately equal. The symptoms of achalasia include dysphagia, weight loss, regurgitation, chest pain. 5% of patients develop squamous carcinoma. Okay, how is it investigated? When you do a chest X-ray, it shows you a widening of the mediastinum, and you see an air fluid level in the absence of gastric fundal gas. Now look at this image. It's very important you understand this. You can see on this image, you will see dilated esophagus and narrowing at the lower esophageal sphincter. and you see air fluid level. Okay, this is air here and this is fluid. So this is an air fluid level. And there's absence of fundal gas. The stomach, if you take a normal X-ray, there's a fundal gas. Now, because there is narrowing of that lower esophageal sphincter, that fundal gas will be absent. Now, so the X-ray, you see widening mediastinum, air fluid level, absence of gastric fundal gas. Barium swallow. When you do a barium swallow, there's a, okay, that is where you see the dilated and residue, you see particles there. Then you have small tertiary contractions and a rat tail of the distal esophagus. Now, if you look at the lower, you see that rat tail appearance or bird beak appearance. So when you see rat tail, bird beak, they are seen in barium swallow of the patient with achalasia. Manometry, there's absent primary peristaltic wave and non-propulsive tertiary contraction. Once you do an endoscopy, it essentially excludes pseudoachalasia due to mucosal carcinoma. And there is tight lower esophageal sphincter, which relaxes with gentle pressure, usually seen, okay? You can also do isotope study. The differential diagnosis now of the patient with achalasia will include diffuse esophageal spasm, infiltrating carcinoma, hypertrophic lower esophageal sphincter, scleroderma Chagas disease. Treatment options, you have non-surgical treatment, which include balloon dilatation, okay, radial balloon. You inflate up to 300 millimeters of mercury for 3 minutes, okay? 3% of patients may develop perforation, 60% dysphagia free for 5 years. May repeat stent if necessary. Usually this is done as a palliative measure, especially in patients that come that are elderly, you don't want to operate, or they have several comorbidity where surgery may predispose them to a lot of issues. Okay. Now, cardiomyotomy is the operation of choice described by Haller in 1914, okay, and Greenveld in 1918. May be performed laparoscopically. 85% are dysphagia-free. 10% develop esophageal reflux, 3% peptic stricture, okay? Some combine cardiomyotomy and anti-reflux operation. Now, if you look at this image now, it's a barium swallow, but however, you will see an irregular feeding defects, okay? Irregular feeling defects. And of course, you see the contrast emptying into the stomach. That is in keeping with esophageal carcinoma, okay? Now, esophageal carcinoma, 90% of this esophageal carcinoma are squamous cell carcinoma, and they occur in the upper or middle third of the esophagus. 8% are adenocarcinoma. So remember, majority of esophageal carcinomas are squamous cell carcinoma. Occurs in lower third of the esophagus. So most of the adenocarcinoma occur in the lower third of the esophagus, while 90%, which are squamous cell carcinoma, they occur in the upper and middle third of the esophagus. Now, overall 5 years survival is very poor and is at best 20%. So you can see esophageal cancer doesn't have a very good prognosis. Anything that will interfere with feeding alone will not have good prognosis. Now, and how much less being a malignant condition, okay? And remember, the esophagus is related to vital structures in the chest, okay? Of those undergoing curative treatment, less than 40% survive 1 year. You can see it's not a good disease. It's not a disease with a good prognosis. The risk factors: squamous cell carcinoma. For patients who have squamous cell carcinoma of the esophagus, the risk factors include alcohol or tobacco, smoking, diet high in nitrosamines, aflatoxins, trace elements deficiency like molybdenum, vitamin deficiency like vitamin A and C, achalasia, celiac disease, genetic tylosis, high incidence of Transky in Transky area of northern China and Caspian littoral region. Adenocarcinoma, 15% associated with Barrett's esophagus. The clinical features of carcinoma of the esophagus, they have progressive dysphagia. Respiratory symptoms due to overspill or occasional tracheoesophageal fistula. They have weight loss. Now, if you are assessing to confirm your diagnosis, you do endoscopy and take a biopsy for histology or cytology at least. You do a barium swallow, which if endoscopy is not readily available, you can see it will show the filling defect we described. Okay. Now, you want to check for resectability and fitness for surgery. You do chest X-ray, lung function test, and all other relevant investigation. Now, the management for adenocarcinoma, it is not radiosensitive. Surgery is the mainstay of its treatment. For squamous cell carcinoma, it can be treated with either surgery or radiotherapy. Okay. Now, don't forget this. We won't go into the details of the treatment. Now, common benign anal conditions include anal fissure, hemorrhoid, fistula in anus. Now, this is a fissure in anus. Okay. This is the anal opening, and there is a fissure usually at 6 o'clock. You can see it has formed an ulcer. And this, when you see fissure like this, with an ulcer, with anal tag at 6 o'clock, that is chronic fissure in anus. Chronic fissure in anus. Now, anal fissure, most acute fissure heals spontaneously. Chronic fissure, those that have lasted for more than 6 weeks, okay, duration associated with increased intra-anal pressure. Now, treatment is aimed at reducing the anal sphincteric tone. Now, don't forget that when there is a tear in the anal canal, okay, that is one of the important risk factor of developing fissure in, and when an individual is passing hard stool, maybe a patient has chronic constipation and he is passing hard stool, and this causes tear in the anal mucosa is the commonest cause, or when there is a foreign body that causes cut in the anal mucosa, or even fishbone. Etiology, probably due to mucosal ischemia secondary to mucosal spasm. Probably not a tear due to passage of hard stool. You see, this is a theory, by pectin band theory. Okay, they believe that it is from spasm. If there is a tear and infection seeps in, there is spasm and increase anal tone. Now, 5% is associated with chronic intersphincteric abscess, usually seen between 30 to 50 years. Now, one important fact you need to understand, most of these fissures are posterior at the midline. Okay, 90% are posterior fissures at 6 o'clock. 10% are anterior fissures, and these ones are related to delivery. Okay, anterior fissures more common in women are specifically postpartum. Okay, if multiple fissures or when they occur in unusual sites other than these, what you see anterior or posterior, you should know that they may be a chronic pathology like tuberculosis, syphilis, Crohn's disease. When you start seeing abnormal fissures or fissures in abnormal locations, start thinking of chronic granulomatous conditions or some other form of chronic conditions. Okay, clinical features: present with pain on defecation, bright red bleeding, and pruritus ani. Fissure often visible on parting the buttocks. They may have sentinel pile. These sentinel piles are called anal tags, and they are usually at 6 o'clock position. Features of chronicity include papilla on the mind edge and visible internal sphincter. Now, there are various treatment options, and the aim of these treatments is to reduce the anal sphincteric tone. You can do a non-surgical treatment by applying agents that will cause relaxation of the internal anal sphincter, and glyceride trinitrate is used as gel. Okay, 0.2% glyceride trinitrate is applied into the anal canal, and patient may have relaxation of the sphincter. Now, you can also use nifedipine ointment, okay, inserting, that will cause relaxation. Now, surgery: 95% achieve prolonged symptomatic improvement. 20%, some degree of incontinence may develop in them, okay? And this incontinence is of flatus because it is the internal sphincter that is inside. So the procedure, the name of the surgery is lateral internal sphincterotomy that is commonly done. Now, this other image you see here is the image of hemorrhoid. And you can see this hemorrhoid appeared thrombosed at the circumferential. You can see bleeding also. Now, you should know that hemorrhoids affect 50% of population over the age of 50 years, and it's usually present with painless, don't forget, it's a painless bright red rectal bleeding. When you see a painful hemorrhoid, it means it is thrombosed. A painful hemorrhoid, patient has developed thrombosis. And usually, it is external hemorrhoid. From internal hemorrhoid that becomes external and thrombose, they become very painful, okay? Because you know that the innervation below the dentate line is somatic, innervation above the dentate line is visceral. Okay, now there's a prolapsing perianal lump, acute pain due to thrombosis, fecal soiling, and pruritus ani. They will be having itching around their anus. What is the pathogenesis? Now, there are various theories about this. We won't go into that, but we'll just take this brief summary. But of all, what holds what is widely accepted is the prolapse or displacement of anal cushions. 80% of patients have high resting anal pressure. The classification of hemorrhoids. Hemorrhoids are often classified as internal hemorrhoids or external hemorrhoids. Hemorrhoids that are above the dentate line are termed internal hemorrhoid. They are covered with mucosa, while hemorrhoids that are below the dentate line are external hemorrhoid. They are covered with perianal skin. Okay. Now, internal hemorrhoid also have a classification by the Milligan-Morgan. The classification, it's classified into first degree hemorrhoid, second degree, third degree, and fourth degree hemorrhoid. First degree hemorrhoid only bleeds, they don't protrude. Second degree hemorrhoids, they prolapse but reduce spontaneously. Okay. In third degree hemorrhoid, the patients have to manually push back the hemorrhoid. That is third degree. He will tell you that when it prolapses, he will manually use his hand to return the hemorrhoid. That is a third degree hemorrhoid. While a fourth degree hemorrhoid is one that is permanently prolapsed. Now, there are various treatment options for hemorrhoid. There is the non-surgical treatment and the surgical treatment. Now, you should know the non-surgical treatment, one will include injection sclerotherapy. When you use 5% phenol in arachis or almond oil to inject into the pedicle of that hemorrhoid, is usually used in second degree hemorrhoids or third degree hemorrhoids. Okay, commonly second degree hemorrhoids. Now, you could have other non-surgical options like rubber band dilatation. Okay, dilatation and banding. The surgical option is hemorrhoidectomy, which is surgical excision of hemorrhoid. Now, there is another that uses hemorrhoidal staplers that is called hemorrhoidopexy. Hemorrhoidopexy is also called PPH. It's called procedure for prolapse hemorrhoid, where an external device, a stapler, is used to excise a segment of mucosa and stretching the hemorrhoid into the rectal cavity. So that is hemorrhoidopexy. But you should know there are non-surgical treatment and there are also surgical treatment. Now, this image is showing a child with a cleft lip and palate. Now, cleft lip and palate is a commonest congenital abnormalities of the orofacial structure. Cleft lip or palate occur in 1 in 600 live births. Isolated cleft palate occur in 1 in 1,000 live births, often occurs as isolated deformities. It can be associated with other anomalies. Now, if you have one congenital abnormality, make sure you look for other congenital abnormality. Now, cleft lip and palate is associated with congenital heart diseases. Cleft lip and palate are of diverse and variable congenital anomalies. Cleft lip and palate predominate in males. Isolated cleft palate is more common. This one is only cleft palate now that is commoner in female. that is isolated cleft palate. But cleft lip and palate is predominantly seen in males, okay? Now, what is the etiology? Cleft lip and palate is believed to have both genetic and environmental components. Cleft palate may be inherited as an autosomal dominant condition with variable degree of penetrance, okay? Family history in first-degree relative increases the risk by a factor of 20. Environmental factors include maternal epilepsy, drugs, okay, like steroid diazepam phenytoin, folic acid deficiency, which is queried here. Cleft lip and palate also occurs as a part of over 100 syndromes. So you can have syndromic cleft lip and palate and non-syndromic cleft lip and palate. Now is the embryology. Cleft lip deformity is established in the first 6 weeks of life and is possibly due to failure or fusion of the maxillary and medial nasal processes. This may be due to incomplete mesodermal ingrowth into the processes. Its extent of deficiency depends on the extent of the cleft. Palatal cleft results from failure of fusion of palatal shelves and maxillary process. Now, the clinical features. Now, what is the pattern of cleft lip and palate? The typical distribution of cleft types is cleft lip alone is 15%, cleft lip and palate is 45%, isolated cleft palate is 40%. Now you can see isolated cleft lip and palate combined has the highest frequency, followed by isolated cleft palate. Cleft lip, again, you should know, is common on the left side. Now, primary management of cleft lip and palate. No, antenatal diagnosis of cleft lip may be possible. Feeding is rarely a difficulty. Breastfeeding may be achieved by a modified teat for bottle feeding may be required. Major respiratory obstruction is uncommon. The aim of surgery is to achieve normal appearance of the lip, nose, and face, allow normal facial growth, and allow normal speech, okay? So when do you do the surgery? There are various techniques of doing the surgery for the procedure, but cleft lip repair is usually performed between 3 to 6 months of age. Cleft palate repair usually performed between 6 to 18 months. 2 or more operations may be required, okay? Now you should know the treatment is multidisciplinary, okay? Other aspects that need to be addressed include hearing of a child, speech therapy, dental, and orthodontics. Anterior abdominal wall defects, okay? Now, you can see these 2 varying images. This anterior wall defect has a membrane covering it, while the intestine is just exposed, okay? The intestine is just exposed. So this is called omphalocele, while this is called gastroschisis. You see, omphalocele has a membrane covering the intestine, while gastroschisis just has a naked intestine, okay? Exomphalus is also known as omphalocele, and gastroschisis are 2 different congenital anomalies, differ markedly in their clinical appearance. The overall incidence is approximately 1 in 3,000 live births, usually diagnosed prenatally on ultrasound. When you do ultrasound during antenatal, you see the defects. You will see the abnormality in the child. So exomphalus and gastroschisis can usually be differentiated prenatally, okay? Do not inevitably require delivery by cesarean section. Okay, now omphalocele and omphalocene always has a sac. The sac may be intact or ruptured. It may be intact or ruptured. The sac, it has 3 layers: the peritoneal covering, Wharton's jelly, and amnion. This is a common question. What are the covering of the, or the layers of the omphalocele? Okay, the peritoneum, the Wharton's jelly, and the amnion. The umbilical cord arises from the apex of the sac. Now, this depends on the type of the sac. It could be major or minor. We won't go into that. Sac contains intestinal loops, liver, spleen, bladder. Okay, it may contain all these things, or it may just contain only intestine. It is often associated with major congenital anomalies. Now, omphalocele, don't forget, the reason why omphalocele will have a poor prognosis is because of other associated abnormalities they may come with. Prognosis depend on these associated abnormalities. Mortality is approximately 40%. So you should know that omphalocele that are associated with other abnormalities have a higher risk of mortality, okay, and poor prognosis. Now, let's just don't go into the details of the treatment, okay? Gastroschisis, of course, it doesn't have sac, okay? You see, it's the umbilical cord arises from the normal place in the anterior abdominal wall and usually to the left of the wall of the defect. So the relationship between the umbilicus and this defect, the umbilicus is usually to the left because the congenital anomaly arises from arrest of the right umbilical artery. So at that place, you have a defect, okay, and may be associated with intestinal atresia, even though is less commonly associated with other congenital anomaly as compared to omphalocele. You should know that omphalocele is more commonly associated with congenital anomalies as compared to gastroschisis. Mortality is approximately 10%. You can see mortality here is lower than omphalocele, but this is not the case in our environment. Mortality is higher in our environment because challenges of managing patients with gastroschisis, okay? One of the challenges is parenteral nutrition, feeding. They have atresia, okay? Their intestine don't absorb most. Can you place a neonate on parenteral nutrition for 6 weeks in our environment? That is really challenging. So they have a higher mortality in our environment, okay? Now look at this bowel, okay? It's showing a segment of dilated segment and areas of collapse segments, and usually of the large intestine. Even this is not a very good picture, but it's an image that is depicting Hirschsprung's disease. Okay, so you should know Hirschsprung's disease. The first thing you should know is the spelling, how to even spell it correctly. Okay, yes. Now, it is due to absence of autonomic ganglion cells in the iliac plexus in the distal large intestine, commence at internal sphincter and progresses for variable distance, approximally affects like 1 in 5,000 live births. Male-female ratio is 4:1. Now, it's commoner in males. Don't forget this. It's commoner in males. Male-female ratio is 4:1. Okay, some appear to be due to autosomal dominance inheritance. 75% case are confined to the rectosigmoid junction. 10% would present with total colonic aganglionosis. Clinical features, 80% are present in neonatal period with delayed passage of meconium. So 80% will have delayed passage of meconium, followed by increased abdominal distension and vomiting. That is features of intestinal obstruction. Account for 10% of neonatal intestinal obstruction. Child at increased risk of enterocolitis and perforation. Now, occasional present with chronic constipation in infancy. Okay, diagnosis. Okay, you have plain abdominal X-ray will confirm intestinal obstruction. When you do barium enema, you have a contracted rectum, a cone-shaped transitional zone and proximal dilatation, anorectal manometry, no rectosphincteric inhibition reflex, no rectal distension. Rectal biopsy, this is very important. Now, when you do a biopsy, there will be absent ganglion cell in the submucosa. Okay, there's increased acetylcholinesterase cells in the muscularis mucosa and unmyelinated and hypertrophied nerve you see in the bowel. So the biopsy, don't forget, you have, it will show absent ganglion cell. 2, there's increased acetylcholinesterase activity. And 3, there is unmyelinated hypertrophied nerves. Okay. So the treatment, initially you have to decompress and do a colostomy. Later you now do a definitive procedure. Because of time, we are going to stop here. I will share you the slides so that you go through other conditions. Because of time, we cannot go through all these pathologies. So I will share the slides, and hopefully when we get today, I had a challenge with my network. By tomorrow, I'm going to sort that problem. So thank you.